Good night, ladies and gentlemen. Welcome to another edition of Healthcare 2.0. And tonight is a very, very special night because in the news we have been seeing recently Dr. Yardesh Singh, who is an advanced laparoscopic surgeon and general surgeon in Trinidad and Tobago. And we have seen a lot of Dr. Singh on the news, and we definitely wanted to invite Dr. Yardesh Singh to come and talk about not only removing the largest gallstone in the world via keyhole surgery or laparoscopic surgery, but also we wanted to discuss with him the whole issue of laparoscopic surgery in Trinidad and the Caribbean. So good night, Dr. Yardesh Singh.
Good night, Dr. Muradali. How are you?
Good, good, good. Well, you have been in the news a lot. So I know definitely when you're a surgeon and you're in the news, that could be a very good thing. It means that you are definitely, doing what we in medicine do best, which is to serve.
Sure. Yes. Definitely, it's a good thing. It's a good thing not only for the individual person or surgeon, but also I think it's also good for awareness in terms of health awareness in terms of the disease processes and the availability of different techniques that we have available as surgeons that we can use for the patient for the better healthcare. And in 2020, there are a lot of advances that we have made in laparoscopic surgery that is not only available in first world countries, but it's also available right here in Trinidad and Tobago.
Very good. Well, we have a lot to talk about tonight. We will get to the removal of the largest gallstone in the world soon. But I want to know, and I'm sure our guests would like to know, who is Dr. Yardesh Singh. So tell us a little bit about yourself, about where you went to school, and what got you into surgery, and then, of course, advanced laparoscopic surgery.
Okay, well, my origins are actually very, very humble. What you call a village boy. And I grew up in the Carpetchima area, and I went to my school actually. It was the Orangefield Hindu School, and from there I went on to the Cuba Government Secondary, and then I went on to Presentation College in Chabonas, where I attained A-levels to do my medical degree. As a little boy, I always wanted to become a doctor. I never wanted to be a fireman. I never wanted to be a pilot or a police. I always wanted to become a doctor. And when I did the A-levels, my dream was to become a doctor. I applied and got in. And during the medical training for 5 years, you are exposed to different specialties. And I actually fell in love with surgery, not only because it was actually very, very hands-on, but it seems like a specialty that you can do something for a patient. For instance, a patient will come in with a gunshot wound. You'll be able to go and operate and save that patient. Patient might have pain in the abdomen from a gallstone. You'll be able to operate and remove that. Patient might have a cancer, colon cancer, pancreatic cancer. You'll be able to go and solve that problem. So it's a very, very rewarding field, especially when you can help our patients. I have been, after my MBBS at the University of West Indies, I actually did a further training for 5 years and then another 1 year training to do subspecialty training. So I did 5 years in my Doctor of Medicine and Surgery at the University of the West Indies. Then I went on to do a fellowship in the laparoscopic surgical oncology, and that was done actually in the United Kingdom. That was sponsored actually by the government of Trinidad and Tobago at that time. It is there that I actually learned a lot of advanced laparoscopic stuff, where we do a lot of minimally invasive. Actually, the unit that I trained on, it was called the Minimal Access Therapy Training Unit. And one of the pioneers in laparoscopic surgery there, Professor Bailey, he actually started that unit. And that is where I attained these skills.
Yes. So for young doctors out there who may be interested in this, it will take them some time to do their studies and all of these surgical training programs?
Of course. My study started soon after internship. My internship actually was in 1999, then started surgery in 2000, and actually it was in 2011 after training that we actually attained the Doctor of Medicine degree, and then went on to even do some further training after that. But it's continuous. This field is continually evolving, and today something might be the hot topic, and tomorrow it might be something different. So it's very important in medicine, and especially in surgery, you have to be on top of your game. You have to also always be in research. And I've also joined the University of West Indies. I'm a full lecturer since 2013, and I am now in charge of training our future surgeons in Trinidad and the Caribbean at the San Fernando General Hospital through the University of the West Indies. Right. So in the past, how surgery was performed is that they have to get into the site that they have the tumor or the cancer or the gallstone or the inflammation, the appendicitis. And in the past, what they would have done was to make an incision on the abdomen. And these incisions normally are very, very large incision because they have to allow the patients, the surgeons and the assistants, instruments and hands to get into the abdominal cavity to the site of the organ. But as time went by, there was evolution in surgery and advancement in surgical technology. And what eventually happened is that surgeons began to make smaller and smaller incisions. So the incision, for example, for a standard gallbladder surgery in 1970s would have been what we call open surgery, which would have been a 15 to 20 centimeter scar in the abdomen. But as time went by, it evolved and the incision became smaller and smaller, even went down to a 5 centimeter incision. However, in the late 80s and the early 90s, a doctor called Dr. Eric New from Germany, he actually pioneered laparoscopic surgery, and he is probably known as the father of laparoscopic surgery. And using instruments and ports, he introduced ports into the abdomen. He used a gas, an inert gas, carbon dioxide, to introduce into the abdomen to have space. And then he used a telescope, and that telescope is what we call a laparoscope, into the abdomen. And we can actually now see on a large TV monitor the target organ. So for instance, if you're looking at the gallbladder, you'll be able to see the gallbladder. And the advantage of this is that the incisions now moved from 20 centimeters to approximately 3 millimeters, 5 millimeters, and sometimes 10 millimeter incision. Now, what I've learned when I went to the United Kingdom, we went on to do, that was in 2008, and what we call single incision or scarless surgery was evolving. And it is there that I was introduced to scarless surgery. Now, if you look at this patient here, the only incision in this patient abdomen is within the patient umbilicus, or what we call the navel. So all the instruments are passed within the navel, and we use special ports. And I've actually went on, because we're in the Caribbean, and sometimes we can't afford special ports. So I've actually evolved and adapted, and I've actually described a new technique, what I call the SILS TT technique, which is single incision laparoscopic surgery, transfascial tunneling technique. And I use that technique to do all my scarless surgery on the abdomen.
Excellent, excellent. All right. So could you tell us a little bit about some of the surgeries that you have done in the Caribbean so far?
Right. So by and large, I've been working at the San Fernando General Hospital as a consultant since 2013. I've graduated in 2011, but in 2013 I became a consultant, and I offer advanced laparoscopic surgery to all my patients in the public sector. Now, the surgical procedures that we offer will be things such as appendectomies for appendicitis, for for gallstones, we do cholecystectomies, and we do a lot of oncology or cancer surgery. So we do, like for bowel cancer, a very common one is the large bowel cancer, or what we call colon cancer or rectal cancer. And actually, just today, I did a very young chap. He was only 38 years old, but I actually performed this operation laparoscopically for him. And this was done at our public hospital in Trinidad and Tobago.
Okay.
We also do gastrectomies for stomach cancers and other types of major operation, like for the esophageal or gullet cancer. And also we also do pancreatic cancer surgery, such as the Whipples or the distal pancreatectomies. And all these are tumors that very common in Trinidad and Tobago. I also offer weight loss surgery or bariatric surgery. Now, bariatric surgery is done for very, very obese patients, and also metabolic surgery. And metabolic surgery is actually a branch of or spin-off from the bariatric type operation. And we actually do this for patients with type 2 diabetes. And there's a resolution rate of almost 70 to 80% of patients with type 2 diabetes if we pick them up very, very early. For instance, if it's less than 5 years, and the resolution is very, very good.
Okay, excellent. Because I've had patients who have had this surgery. They were previously diabetic, type 2 diabetics,
Yes.
and they were obese. And then they came back after the surgery about 6 months later, and there was no need for their diabetic medication. So that's an interesting area of research, I know. And I'm sure, at some point in time, we could probably discuss the whole issue of bariatric surgery in Trinidad and the Caribbean.
Yes, it's a very it's a very interesting topic, and in itself, in terms of type 2 diabetes being a very, very common condition. And actually, you're looking at, we in surgery don't like to call it a cure, but if you can actually get a patient off the medications, the diabetic oral medication, even sometimes insulin, that's a very, very positive thing for the patient and also for your health system.
Yes, of course, agreed. So these are some of the cancer surgeries you had mentioned.
Yeah, so we also perform, actually center that I trained in, we actually trained in esophageal or gullet cancer and gastric or stomach cancer, and actually offer the minimally invasive approach to these tumors. And recently we published our paper on minimally invasive esophagectomy here in the Caribbean, and it was the first case that was performed. We also, as I mentioned before, we also do a lot of colon cancers and rectal cancers and the pancreatic type cancers.
Okay. So very importantly, somebody who is accustomed to surgery, their neighbor is going for surgery or their family is going for surgery, and they're told, oh my God, they're going to have to open up the belly. That's the common understanding, that somebody's abdominal wall is going to be opened in this procedure. What you're talking about is something that does not necessarily require that to be done. So
Yeah.
Obviously, there will be advantages for the procedures that you do versus the open type of surgeries. So, you could probably elaborate a little bit about some of the advantages of laparoscopic surgery.
Okay. Because of the very, very small incisions, I'm talking about 3 millimeter incisions and 5 millimeter, and sometimes 1 centimeter or 10 millimeter incisions, the pain that you will experience from these very, very small incision is very, 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 very small. Sometimes patients can actually be discharged the same day after surgery. And on oral pain medications, something as simple as Panadol. So there's reduced pain after the surgery because there's reduced trauma or cutting onto the abdominal wall through the muscles. Also, because the incisions are very, very small, I mean, it is simple and logical that the cosmetic outcomes, if you don't have a 25 centimeter incision, you have a very, very small incisions, they have very, very good cosmetic outcome. And because a combination of a little bit of pain and better recovery, patients can actually go home the same day. So a lot of my patients who have gallbladder surgery, they can actually go home on the same day. So they have a laparoscopic cholecystectomy in the morning, and by afternoon, they'll be up and they'll be able to walk, they'll be able to have something to eat and take their medication, and in the afternoon, they're back home in their house. Now, the advantage to the public system is they decrease in terms of hospital stay and decrease in terms of bed space and occupying patients' bed. So it opens up a lot of bed space for other more ill patients.
Yeah.
As I said, there's shorter recovery time, and some patients, they get on to their normal daily activities. They can actually faster return to work, and then that also benefits the public system and also the private system, because you have your worker, they come back out to work and they benefit for everybody.
Yeah, so there are definitely advantages, major advantages, I would say, of laparoscopic surgery versus the open type of surgery.
Definitely. Right. So this I'll talk a little bit on the advanced laparoscopic surgery, which we call scarless surgery or single incision laparoscopic surgery. And in this type of an operation, again, it's laparoscopic, but the only incision that you will have is through the navel or your umbilicus. So a very, very small incision, and I make what you call a S-type incision within the navel, and then we introduce ports. And this photograph demonstrates the instruments through that small incision and actually pass 3 different ports within that incision, using the refined tunneling technique. And we introduce the camera through the middle port, and you see me holding there on the left hand and right hand 2 other instruments, and these are called graspers. And through these, we look onto a monitor, a screen, and you'll be able to see actually the organ that you'll be able to cut arteries and veins and clips and do the operation through this. And this is what it looks like. So this patient actually, it's a single incision cholecystectomy or SILS cholecystectomy. This patient actually had a gallstone and was having severe abdominal pain. And this is what the incision looks like afterwards. The only incision you have is the same scar that you would have within the navel.
Amazing. I'm watching this and I remember my days before SILS and before laparoscopic surgery, my days on the ward.
Yes.
When somebody had their gallbladder removed, there would be a huge scar.
Yes.
The patient would be there for days on the ward. And
normally the scar is actually between 15 and 20 centimeters, and it's on the anterior abdominal wall. And then the patient has to stay for almost 5 days, sometimes even 7 to 10 days on the ward.
Yeah.
And this patient here, she presented with acute appendicitis, and we preserved her abdominal wall. It's a young lady. They're always aware about their scars on their abdomen. So we preserved her abdomen and kept her only scar that she came with, the umbilical scar. So we went on and we did operations that involved more advanced work, which was like colon cancer and rectal cancer. And I'll show you some of the cosmetic outcomes that we got with it. So this is a patient who actually had right-sided colon cancer. And we did a single incision laparoscopic right hemicolectomy. And this is what the cosmetic outcome looked like. This patient had another cancer. This cancer was still in the large ball, but on the left side, the opposite side, very common spot called the sigmoid colon. This patient had sigmoid colon cancer. And if you look at this abdomen, you can hardly see, hardly see any scar. I mean, this is virtually scarless.
Yes, of course.
Now this patient, if you look just below the navel, there's a little darkened area. And because this patient tumor was a lot larger, I had to actually incise the abdominal wall about 2 or 3 centimeters just below, and still the patient had a very, very good outcome.
Very good outcome, yes.
And this patient actually had what we call a metabolic surgery. Patient had type 2 diabetes, and I did a single incision laparoscopic sleeve gastrectomy on this patient. And so a sleeve gastrectomy gastrectomy is when you reduce the size of the stomach to a very, very small, slender stomach, almost like a banana size. And I did this entire operation through the navel, and the patient type 2 diabetes was reversed, and the patient was completely off his medication.
Excellent.
And this is what a cosmetic outcome looks like. In this young lady, she actually, if you look on top, above the navel there, she has what we call a navel ring. So sometimes patients come with little requests, and we try to preserve. So because I do my operation through the umbilicus, I was actually able to preserve her navel ring.
Amazing. So there's a whole area of surgery called bariatric surgery. A lot of patients come to me and ask about it because my type of work is mostly offshore medicine. So persons have to go onto certain rigs, platforms, they have to use a helicopter, and they may be obese or morbidly obese. Their body mass index is 35 and greater, 40 and greater.
Sure.
And many times, they need maybe a surgery to lose the weight. So take us through what bariatric surgery is.
Sure. So bariatric surgery actually, for a more simpler term, it's called weight loss surgery. And what we do for patients, what we know is that patients with a high body mass index above 40, they have a lot of long-term problems in terms of comorbidities. They will go on to develop things such as diabetes and hypertension. They will obstructive sleep apnea, osteoarthritis, and problems with their knees and their backs. So a lot of these patients, they come and they would have tried. They really tried. They tried to lose weight, and they would have had what we call the yo-yo type diets, and they would lose about 50 pounds. And then within the space of another month, they will put back on the 50 pounds. And some will really go to the gym and have structured exercise programs and have a personal instructor, and they still will lose the weight and they will put back on the weight. And like for a lot of my patients, I always implore on them that they always have to have a correct mindset. And having a correct mindset means that you should have gone through your diet program, you should have gone through a structured exercise program for weight loss. And after failing these non-surgical means, then I will consider a bariatric type procedure. And one of the achievements of it is that they can actually lose weight, and they will lose between 60 to 70% of their excess weight. So for instance, if a patient, like for instance, this patient he came to me, he had about 440 pounds. And within the space of a year, he actually lost, and he came down to about 200 pounds. And if you look at the next photograph, this was the patient before on the left, and this is the photograph of the patient on the right. And this is within 12 months. Now, so bariatric surgery is good. So patients who has type 2 diabetes and hypertension, hypertriglyceridemia, and high cholesterol, once they lose the weight, sometimes they even be able to come off these medications, such as the diabetes medication, hypertensive tablets, and cholesterol medication.
Yeah, but they should also continue with their lifestyle changes in terms of your diet, their exercise, and all of those things.
Yes, so a cornerstone, a very important part of, I tell my patients, they have gone through the hard part to make a decision to have surgery. And would have surgery, it's not an easy thing to consider. And once they have gone through this, they must also have a lifetime commitment in terms of their lifestyle changes, in terms of the diet and exercise. And they have to maintain that to maintain their weight.
Right. So we've reached the moment that people are talking about in terms of this giant gallstone. But before we get into the giant gallstone, could you just tell us a little bit about how a patient with gallstone or gallbladder disease usually presents?
Yeah. So the typical patient with gallstones, or what we call gallbladder disease or gallstone disease, is that these patients are normally female, and they're normally around the age of 40. So we have a little rhyme in medicine that I knew as a medical student, is normally a fat, fertile female in her 40s. So that basically sums up the typical patient. So it's a female patient in their 40s, and they're normally a bit overweight. And they will typically present with severe abdominal pain. But this pain actually comes on after eating oily foods or fatty foods. So a common thing in Trinidad and Tobago is that they may have fried chicken, or they may have adobols or aloo pie, and then suddenly about 30 minutes later they're having severe abdominal pain and nausea and vomiting. Now this could be very, very excruciating, and they could actually go on to have things such as fever and actually have to be hospitalized. Now, some long-term problems that they get with it, if this doesn't settle down, these patients may actually have to have emergency surgery because the gallbladder may become infected, and you may get inflammation and abscess within the gallbladder that we call empyema. Some patients may even develop jaundice because stones actually move into a different part called the common bile duct and cause a blockage, and the patient's eyes become yellow, and that is what we call obstructive jaundice from gallstones.
Yes, of course. So in the patient that had the giant gallstone, how did that patient present? What was the age of that patient? Is there any other history, of course, that you would like to share with us about that patient?
Well, I must say she was a very, very pleasant lady. She actually reminded me of my mom. I will say an older East Indian woman, and she was in her 70s. However, very interesting in her story is that she actually knew that she had gallstones when she was 40 years old. And at that time, the gallstone, she said, was very small. But she ignored it, and she would intermittently get pain during those 30 years, and she would take her simple painkillers. But by the time she came to me, she was having excruciating abdominal pain, nausea, and vomiting. They went on to do a CT scan of her, and when they did the CT scan, they saw this huge, really, really giant stone within the gallbladder. She came to me actually after seeing other surgeons, because when they saw this large stone, they said they will only be able to do it open, or the traditional open surgery, making these big incisions on the patient's abdomen. After speaking to the patient and looking very, very closely with the scan, I thought I would have been able to perform this operation using the minimally invasive laparoscopic approach. We went on, and this operation actually took us a little over 1 hour, very straightforward, and saw a lot of attention on the media. It's how we removed the gallstone. And if you looked at my previous slides, through the umbilicus, the navel, then that navel can actually give you between 5 and 7 centimeters in terms of incision length. And I placed this into a bag and removed it very carefully through that navel. And she had a very, very good cosmetic account postoperatively.
So this is the gallbladder, and the stone is still inside it, one stone.
Yes, so this is one giant gallstone within the gallbladder. Now, giant gallstone by definition is defined as gallstone greater than 5 centimeters, which in itself is not very, very common. There was one gallstone that was done a little smaller than this, was actually 9.5 centimeters. So after I looked into the medical literature, did some research, and when we took this gallbladder and measured it and went into medical literature, we realized that this probably would have been the largest gallstone that was removed laparoscopically in the world. And we went on, and the rest is history. We published it in the medical literature. So this is after the gallbladder was removed. I actually made an incision on the gallbladder, and the stone, you see this stone was occupying the entire cavity of this distended gallbladder.
Were you surprised when you cut the gallbladder and you saw this?
Yes, I was a bit surprised because sometimes you may see these things on the scans, and then when you actually open the gallbladder, maybe one or two or three stones actually come forming a image of a larger stone. When I saw this, I was really surprised.
Yes, of course. And this was the
Yeah, so that's
stone.
the stone. And actually, I find it looked like a avocado, a very ripe one. And on that afternoon, I actually came home, sitting on my kitchen countertop, and that's my countertop looks like. And there was an avocado sitting there, so I quickly took a bit here, and then we compared them. And then later on, I started to tell all my students and my residents that we took out an avocado stone out of a patient. Yeah.
Yes. So what happened to the stone? I think everybody wants to know.
Right.
What happened?
What we do with these stones is when we remove the gallstones, we always give it to the patient. We always give it to the patient because it's like a pearl. I know it's a little talking point, and they can tell their kids and their grandchildren about, this is a stone was found within me, and if you ever read the pearl, something similar. But yes, I actually took it. I gave it to her, and she took it home. And then she visited me post-operatively, and about a month later, she actually called me and she said, Dr. Singh, I would like you to have this stone. And actually, the stone is in my possession.
Okay.
I actually have the stone at home.
Do you have it in formaldehyde or any
No. What happens to these is after a while, because of its makeup, it's normally highly concentrated in cholesterol. What happens if you leave it in liquid, it will dissolve, and then if you leave it like this, it disintegrates. So eventually, it will disintegrate and into smaller pieces.
Okay. Mm-hmm. Well, I think that answered the question. A lot of people were asking, I know, on Facebook and other media, what happened to the stone? Did the patient keep it? Did you all keep it? Yeah. So I'm happy that you answered that question.
Yeah.
So that is the issue there with the whole the giant gallstone. I mean, I must say, as a fellow medical practitioner, you've done a fantastic job at her age, to really have an open surgery may have been rife with complications, so doing this laparoscopically through SILS, was definitely a plus for the patient.
Of post-operative recovery afterwards, she actually wanted to go home, but I told her no. I said, no, I'm not going to send you home. She was up and moving and walking. She was having her tablets, and in the afternoon. But I'm a surgeon, but I'm also a doctor and a human. I don't like to force things onto patients. So I told her, no, let's stay till the next day. Let's make sure that everything is fine with you. And she left very early on Sunday morning for home, and she has been fine ever since.
Good, excellent stuff. Right, so tell us about how this ended up in a journal and this.
Right. So if you see, I must pay tribute to the authors here. So I'm the surgeon and the first author, Yardesh Singh. But if you look at the other authors, Siddiq Mohammed, Akila Hussain, Kurshival Ramuta, they are actually my residents. All right. So Siddiq Mohammed actually is one of my present resident, and he's actually in his year 4 program of his DM. Kurshival Ramuta, he's now starting off. He's in his year 1, recently accepted. And Akila Hussain, she is one of my past house officers. You'll see Professor Vijay Narayan Singh there. He helps us a lot in terms of our writing of the papers and editing of the papers. So this is what the team, it's always about teamwork, and this is what the team consists of. So at various points in time, the team may change as my residents rotate around. So different residents may contribute to different papers. And we went on and we published this. And actually, this was a birthday present to me, because my birthday is on May the 3rd, and this paper actually got published on May the 2nd.
Very good. That was a good birthday gift.
A very good birthday gift, yes.
Right. So next week, well, this whole month, the month of November, is Pancreatic Awareness Month. And next week, 1 week from today, is actually Pancreatic Awareness Day. And I know you earlier spoke about using laparoscopic surgery in pancreatic cancer. So maybe you can just touch on it a little bit. I know next week you'll probably be very busy. A lot of media houses, a lot of people probably want some interviews concerning the whole issue of pancreatic cancer.
Yeah.
We have all lost somebody with pancreatic cancer, and we know how difficult sometimes it is to make a diagnosis. And then, of course, the whole issue of treatment. So could you just run us through a little bit about the pancreatic cancer?
Okay. I mean, pancreatic cancer, as I said, we have all had someone who you knew or somebody within the family who have had, and I have actually had the personal experience of family members passed away with pancreatic cancer. And it's really one of the tumors that really has a very, very poor outcome because of the fact that when we detect it, sometimes it's a little bit too late. We have other cancers such as colon cancer and breast cancer and cervical cancer where we have very, very good screening tools. Screening tools mean that you can detect the cancer very, very early. However, we haven't advanced that far enough, especially in terms of pancreatic cancer, to have a screening tool that will detect the pancreatic tumors very, very early. And unfortunately, when we detect them, it's a little bit too late, and patients normally present what you call irresectable or with metastatic spread. And these tumors, they can grow anywhere in the pancreas. They can grow in the head of the pancreas, they can grow in the body of the pancreas, and they can grow in the tail of the pancreas. And the pancreas is the organ that sits very, very deep in the abdominal cavity, with what we call the retroperitoneal area. So it's really, really hidden up within the abdominal cavity. This is a patient I actually did, and he presented to me. He had a very, very large pancreatic tail tumor, and his pancreatic tail tumor was actually involving several organs. It was involving the colon, it was involving the adrenal gland, which is a gland that sits on top of the kidney, and that on the right there, the right of this photograph is the spleen, and just right next to the spleen, it's that big lesion next to the spleen there. That's the tumor. Yes, that's the tumor, and that big tumor. And we actually did this laparoscopically, and he was a 70-year-old man, and we accomplished this laparoscopically. Fortunately for him, he is still alive, and he is now 6 years post-surgery without any recurrence, and a very, very happy camper.
Yeah, well done. Well done.
Yeah. This is another patient who would have presented to us. This patient, if you see, that's a very, very huge mass just above the kidney. Yes, that's it. That's a huge mass. That was almost the size of a football. I think this would have been probably close to about 10 centimeters or 12 centimeters inside. And we did this laparoscopically also.
Yes.
And this is what it actually looked like, right? So that's the tumor, that big bowl-like structure, that's the tumor, and the spleen is also attached onto it.
How did this patient present to you all?
She actually just presented with abdominal pain. She had abdominal pain. She went to her general practitioner. He palpated or felt her abdomen, and he thought he felt a mass. And I must commend the general practitioner for that. And he went on to do an ultrasound. And when he did this ultrasound, he saw this. It was reported as a tumor that was emanating from the pancreas. Yes. And then he sought the help of a surgeon. So the patient actually came to us. We went on and did a CT scan and then surgery.
Okay.
So this also is a similar case, similar type of presentation, severe abdominal pain. She presented actually with severe abdominal pain, a younger patient. And she actually had a CT scan done right away. She presented to the emergency department. And sometimes these tumors, what happens, they grow for a long time. And then sometimes why you get the severe abdominal pain, that they have to go to the the doctor is that sometimes there might be a little bit of bleeding within the tumor. And when it bleeds, it's stretched, and the pain fibers gets activated, and then patient gets pain, and they seek help.
Yes.
And this is what hers look like. So this tumor, that's the tumor, within the pancreas. That's the pancreas, and we had to remove the spleen. Yeah.
Okay.
And this is what one of the patients who look like postoperatively. So these are the very, very small incisions within the abdomen. And so these are like 3 millimeter incision, and the bigger one around by the navel area there, that's the incision that we'll normally make to remove. So the specimen is placed in a bag to protect it, and also to protect the patient from spillage, and it's removed very, very gently through the umbilical incision that you would have seen in the past.
Yes.
And this is a very, very this patient actually presented very acutely to the hospital, and she actually had jaundice. So this is probably one of the most common presentation of pancreatic head cancers. Patient present with jaundice, which is yellow discoloration of the eye, and they normally will have sometimes a bit of itching of the skin and colon, urine. And the stool sometimes become little less brown, more lighter color, like sometimes they describe it as gray. But jaundice is really the main feature, and some may have weight loss. So if you look at the tumor there within the head of the pancreas, within the head, just to the left of that, that's the tumor within the head of the pancreas, and that's the gallbladder there. It's a bit shrunken, and this tumor was sitting there and slowly growing until the patient became jaundice. We went on and we did a CT scan, and this is actually demonstrating a very good, a sign that we call a double duct sign. And normally when you see this double duct sign, it's very ominous sign that the patient may have a tumor. So this actually was a pancreatic head cancer. We went on and we did this operation. We did it laparoscopically, and we did a totally laparoscopic Whipple's operation. And we got this published also in March of 2020. And this actually was the first case of a laparoscopic Whipple operation being done in the Caribbean.
Excellent. Yeah. And the team of your team, I see again.
Yes. So the same team is there, and actually, when I do these type of operations that are very, very complex, I don't do them by myself. I also get a senior surgeons involved. And so in this case, actually, I did this case together with one of my very, very senior and dear consultants, TV Gorvilla. And so both of us did this operation. And it took us a little bit about maybe close to 10 hours. Patient was fine postoperatively, and on day 2 she was back onto the ward, and on day 5 she was home.
Was it around back when we were in school together?
It was pioneered in 19. So we would have started in 1993, 94. That was the pioneering time of laparoscopic surgery. So it's really, really present in really the first world centers. It was really in America and United Kingdom and France, and eventually it spread out to the rest of the world as people became more and more trained in it. And then there are large centers like the one that I went to train. They train thousands of surgeons per year. So it is very common now for surgeons to perform laparoscopic surgery, especially what we call, I mean, in surgery nothing is basic, but we call some surgery simple operations, such as the appendectomies, appendicitis, and gallstones. We do cholecystectomies. But more of the advanced laparoscopic surgeries, that the cancer surgeries, they're actually done in only a few centers. Fortunately for my patients, I work at the hospital. Wouldn't say which one, but I work at the public hospital, and I've been working there for 20 years. and I offer this service to my patients, and by and large, most are happy.
Yes, very good. Well, on behalf of your classmates, on behalf of your medical colleagues, I must say how very proud we are of you. You have definitely, advanced your career in part of medicine into surgery, into laparoscopic surgery, small incision laparoscopic surgery, and you continue to advance and do some very great things, helping our population with their medical illnesses. From my point of view, I mean, I wish people would, get their annual checkups, so that we could detect any disease early, which usually has a better prognosis. So definitely, we make a plug for that. But I must say that, you're doing fantastic work in the field of surgery, and I definitely want you to keep it up. We want to see more things published, more firsts, and I know with this whole issue with the large gallstone, you did bring some awareness to the whole issue of surgery and the advances in surgery. Any closing comments?
Well, I would just like to thank you, Dr. Morali, I'll call you Navi. Thanks for this opportunity, for allowing me to present to the rest of, to your audience, and hopefully to a lot of patients in Trinidad, of things that is available here. And you don't have to leave Trinidad and Tobago to access this type of healthcare. It's present here, right here in Trinidad, and it's also present at the hospital for free. Okay. Yes, there's private healthcare, but I think for me, one of my contributions I'm making, not only in terms of teaching and training of our future surgeons, but I also offer my services free of charge through the public and to the public. And there are a lot of patients who cannot afford healthcare, and I think there's no reason that they can't enjoy what we will call modern medicine and modern surgery.
Yeah, very good. Thank you so much for that. So, we know that you've been you have a busy schedule. You took your time out to talk to us, today. You probably have more medical work, more surgeries today and tomorrow. So keep it up, and we will definitely have you back at some point in time in Healthcare 2.0 to talk more about some of the surgeries, the advanced laparoscopic surgeries you spoke about briefly earlier in the program. Okay. So thank you very much again.
Thank you very much.